I present you Acromio clavicular disjunction. In fact, the shoulder is a suspended joint. The clavicle joins the upper limb to the trunk through the acromioclavicular and the sternoclavicular joints, and the muscle play the role of struts to stabilize the shoulder on the superior trunk. The AC joint is stabilized by many ligaments. You see the AC acromioclavicular ligament with the capsula, but there is also extra articular ligament that allows the stabilization of the joint, the trapezoid ligament, the conoid ligament, and can be broken during the AC joint dislocation. So how does it happen? In fact, most of the time it is a supraacromial impact. You can just have a sprain, so it is only one point that is broken, and you can have a dislocation with more than 2 points. Which are the points? It is the AC joint and the coracoclavicular ligaments and the trapezius aponeurosis that is broken in the higher stage of the dislocation. Rockwood make a classification that allows to understand which kind of dislocation we have and to try to understand which kind of treatment we can apply to this dislocation. How to make the diagnosis? Most of the time it is a clinical observation because you can see that there is a mobility of the clavicula in the vertical plane and in the horizontal plane. You have that we call the piano key, and you can play with the clavicule as an anterior-posterior drawer. It's important also to make X-rays. You can have en-face view to see how the clavicula is elevated, and you can do axillary X-ray, especially if you don't have the CT scan, to appreciate the anterior-posterior dislocation of the clavicula. The CT scan is very important, and most of that, the arthro CT, is very interesting because, as studied, we have 40% of intra-articular associated lesion that can be seen. It could be instability lesion of the rhabrum, but it can also be cuff tear, for example, supraspinatus curve or infraspinatus cuff tear. What about the treatment? For AC dislocation, how to choose? Type 1 or 2, it seems like a sprain. You can do orthopedic treatment. So you can put a sling and make early rehabilitation. For stage 4, you see there is a posterior dislocation of the clavicula. It's better to make a surgery. The same for the type 4, with the detachment of the trapezoid and the deltoid. It's that case, there is no hesitation, you have to do a surgery. The problem is for the type 3, that it's a superior dislocation that is reducible and with the functional treatment don't have a lot of impact on the clinical function. So, what to choose, orthopedic treatment or surgical treatment? It's a case-by-case choice, according to the age, the sport, and the clinical deformation. Some people try to do hook plates, but the device had to be removed because it's bothered under the skin. Most of the time you have to remove it at 1 year. Osteolysis, scale problems, or implant migration. Endobutin is our choice. We'll see a movie about that. And finally, we have some tendon graft that could be used in other teams. Here are our techniques. So the patient is positioned in a lazy beach position that allows low blood pressure without risk for the brain. Then you go in the joint to see if there is some associated lesions. Here is the biceps, the cuff, and then you go under the coracoid. You see the subscap tendon under the coracoid. Here it is the device to make the drilling. So you put this spatula under the coracoid, and then you position your drill through the clavicular and then through the coracoid. It allows you to make a shuttle relay with the double button. Here is the suture. you can take through the lateral approach. And then you can, here is the button with the two buttons, the coracoid one and the clavicular one. You have to bend the coracoid one to be more anatomic, and you use the shutter relay technique to pass the button through the coracoid and the clavicular, and then you tighten your knot to reduce the clavicular just in face of the acromion. And it's down. Here is the final control X-rays. Take-home message, the AC dislocation is most of the time traumatic. It has to be treated in emergency, lower than 10 days if needed. 40% of intra-articular associated lesions that makes the patient going to your clinics a few years after. It's a minimally invasive technique that allows a reliable treatment because chronic treatments are very more invasive with less predictable outcomes. Thank you.